Hello, welcome to this EHA Multiple Myeloma podcast series. My name is Pieter Sonneveld. I'm a professor of hematology in Rotterdam, the Netherlands, and working on myeloma research and clinical. The EHA has introduced a series of podcasts that are focusing on high-risk myeloma, cytogenetics, and other disease conditions that may be potential a threat to the patient. So we already had one podcast with Professor Terpels from Athens about patients presenting with renal impairment. And today we will focus on another specific topic, which is high-risk disease and cytogenetics. If you want to access these podcasts and other associated resources, please visit the EHA Campus at www.ehaweb.org. It's my pleasure today to welcome Professor Katja Weisel. Professor Weisel is from the Eppendorf University and Clinic in Hamburg, Germany. And she's a well-known international expert in the field of multiple myeloma, and especially also she is running a trial for high-risk patients. So we would like to discuss with her today a couple of situations and conditions in myeloma patients that relate to high-risk features. Professor Weisel, would you like to introduce yourself?
Thank you, Peter. Great pleasure being here and discussing with you this important topic. Yes, I'm working here at the University Medical Center, Hamburg-Eppendorf, and I'm a professor of hematologist and very interested also for a long time in multiple myeloma, especially in clinical trials on difficult to treat patient groups, and I'm looking very much forward to our discussion.
Thank you. So we will start with the topic of cytogenetic abnormalities and markers of poor prognosis. Of course, there's a lot of literature about it, and throughout this discussion, we will also emphasize that if you want to read more, please look at the EHA Campus or in the international literature. So, Professor Weisel, may I say Katja for today?
Absolutely.
Can you briefly summarize what is high-risk disease in multiple myeloma?
Yes, multiple myeloma so is high-risk disease, to my opinion. It's always a very heterogeneous disease, and even in the individual patient heterogeneous. And we are very clear, I think, that we have a subgroup of patients with still an overall survival of only about 2 or 3 years, and these are our high-risk patients. But it's more complicated to design them. I think we divide a bit between the cytogenetic defined high-risk disease and also the clinical high-risk disease, including patients who primarily present with plasma cell leukemia or extramedullary lesions or high LDH, who also have a clinical course of high-risk disease.
Yeah, so it's very important that you mentioned that. So high risk is not exclusively cytogenetics, there's more. But for today, we will focus on the cytogenetics. So can you explain to us what are the main and most important cytogenetic markers of high-risk multiple myeloma?
Yeah, I think we have 3 really well-established cytogenetic markers, and the most common of those is the deletion 17p, and then followed by the translocation 414, and very rare but also important, the translocation 1416. And those are the 3 abnormalities where we, I think, uniformly agree that those define cytogenetic high-risk disease. However, we are in a continuous discussion to include more, and this in regards of aberrations, also in regards of cutoffs, and also whether to include the tumor burden of myeloma disease in combination with the cytogenetic aberration, then coming to our staging system.
Yeah, so these markers, are they independent or associated with each other? And what is the global impact of these high-risk markers?
At the end, I think they normally are, or they deal separately from each other. However, we have also patients where we have more than one high-risk aberration, and I think although the systematic data of those patients are rare, we can say that they have even an adverse prognosis when combining more than one cytogenetic aberration. And you did a very nice, or include that very nicely in your publication on high-risk disease, that those patients with equal or more than two cytogenetic high-risk characteristics have an overall survival even of less than 2 years.
Yeah, so when we go to the routine clinical practice, I think most clinicians use FISH diagnostics for cytogenetic abnormalities. But are you of course, you are aware of other genetic markers in high-risk myeloma and other techniques. Can you briefly comment on that?
Yeah, I think first of all, FISH analysis should be standard of care for all myeloma patients, independent of age, even independent of frailty, and it should be always done on purified plasma cells. However, as we both said, we move forward, and I would like to point out one discussion on one cytogenetic abnormality, which are which is the amplification on chromosome 1q. And when we have more than one or even repetitive copies of 1q21. It was for a long time, from my feeling, a better controversial discussion about the impact of this. And I think recent data clearly showed that 1q21 and the increasing copy numbers is a clear feature of high-risk disease and should be included in the high-risk population. We, from our German cooperative group, had early data on this, and this was why we also included those patients in our trial here, but now there are emerging data everywhere. And I think one key publication on this was in 2018 publication of colleagues defining the so-called double-hit myeloma, and they used also a different technique to look on high risk and did a genomic analysis and showed that either the B allelic loss of TP53 or the equal or more than 4 copies of 1q21 together with a high tumor burden is also a character of high risk, and they defined it as double-hit myeloma.
Yeah, so you are also aware of the recent meta-analysis of the Harmony program with EMN of thousands of patients that showed that 1q21 amplifications.
I think the Harmony big data platform as a European initiative is an absolutely very important source of generating those data, and it serves for a panel of hematologic diseases. And I think one of the most important works out of it in regards of myeloma was the revision of the revised ISS staging system, now defining in the era of even more novel agents 4 risk subgroups, which very well separate from each other, coming from low, intermediate, high, and high risk. And this revised or R2 ISS score, and you were also responsible for this important analysis then, respected deletion 17p, translocation 414, and the abnormality on 1q, together with the ISS 2 or 3 disease and the high LDH, to separate out these 4 groups. And I think this is for the clinical and daily experience a very important staging. It's easy to use, as all information is available with the normal myeloma lab values and the initial FISH analysis. You don't need gene expression profile or something very special. And you can give the patient or yourself really very distinct prognosis on their potential disease course.
So you briefly comment to gene expression profiling, and I would also add this next generation sequencing, new tools, relatively new tools. I think not yet in clinical practice. Do you think they have a place in clinical trials or elsewhere in the diagnosis of myeloma?
I think so far we cannot speak the final word on this. The gene expression profile, to my knowledge, there are 2 approved GEP panels for myeloma, however, not consequently reimbursed. So also in Germany, so that it did not enter so far due to the lack of reimbursement, the clinical routine. In general, it's probably more specific what we know from the data. I think, however, and if it really will add value in the sense of better defining our high-risk population, I think the final word is not spoken. For NGS, I personally also accompanied an analysis in the large daratumumab approval trials, introducing daratumumab in relapsed disease in combination with standard of care treatments, where the cytogenetic analysis was not done by FISH but by NGS. And we did a correlation analysis with the local FISH data, and this is clearly an alternative, but if it's really an advantage, I'm so far not sure.
Okay, thank you. So to end this part of the podcast, what is your advice to the colleagues in the regional and local hospitals? What is the standard package of cytogenetics in a new patient?
Absolutely, I would say FISH analysis in a dedicated lab, and this should at least cover a deletion 17p, translocation 414, 1416 if available, and the abnormality on chromosome 1q. I would also always add, despite it's not a high-risk feature, the translocation 1114, as first of all, it shows a distinct biology in the myeloma disease course, and second, we have a druggable target with that, with the not approved, but hopefully approved in the future, our drug venetoclax.
Okay, thank you. Then coming to the, let's say, the impact of cytogenetics on outcome of patients. We have, you already mentioned a few trials where cytogenetics were analyzed. Can you briefly comment if these new trials, these new treatments, especially with the immune treatments that are now coming our way, how cytogenetic abnormalities affect the outcome of those treatments?
I think that high-risk disease is, or the outcome of high-risk disease is clearly improved, where the novel possibilities we have combining different mode of actions and doing quadruplet treatments in front, combining monoclonal antibodies, anti-CD38 antibodies together with proteasome inhibitors and immunomodulators. However, I don't think that we are there, that those strategies do overcome for all high-risk patients the negative impact of high-risk disease. From the point of you looking on our trial combining isatuximab, carfilzomib, lenalidomide, dexamethasone, or also the trial of the British colleagues doing something very similar, I think we see that for a majority of high-risk patients, we can clearly improve the outcome and can prolong progression-free survival and can overcome the initial problem that those patients respond, but very, very early relapse. However, we have still some, I would say, ultra high-risk patients which we still lose with those strategies, and they might need a total novel or innovative strategies from the beginning on. But overall, I think we made a major improvement in combination treatments with combining the best we have.
So in your practice, do you already make clinical decisions, therapeutic decisions, based on the results of the cytogenetic risk group?
Yes, we do. Normally, we try to include all patients in the trial. However, this is not always possible. So for patients outside clinical trials, we clearly recommend, especially for high risk, but for all patients, a quadruplet treatment approved in Germany. In Europe is daratumumab VTD, based on the Cassiopeia trial, and also the subgroup analysis of high-risk patients in Cassiopeia showed a very promising outcome. And what we do personally also from according to the work you did and your co-workers, that we propose a tandem transplant for all patients outside clinical trials with high-risk disease, as we are convinced that transplant-eligible patients do benefit from a tandem transplantation in outcome, despite it was not done in the context of quadruplet induction. However, we are convinced that the results still support this, especially as we have approved the lenalidomide maintenance for all patients. And we know that it's also beneficial for high-risk patients, but we have all the feeling that it should be probably extended, if we could wish, to do that for high-risk patients. Why do we do this, and why are we so strict in this recommendation? We believe that achieving a maximum of remission, especially a minimal residual disease negative state, is crucial, especially for high-risk patients, to maintain the remission. And when we try to deepen the remission at maximum as we can, even outside of clinical trials, we the patient should have a benefit out of this. And this is the reason we are here in the recommendation more extensive for high-risk patients as we are for standard risk patients.
Okay, now you referred already to new treatments and whether they are so effective that they might abrogate the negative prognostic impact of high-risk cytogenetics. Now, many of these treatments are not given frontline, but at first or later relapse. So my question is, would you perform again a cytogenetic test when you start relapse treatment? In other words, should we repeat the FISH at any relapse or progression in order to assess the prognostic risk group of the patient?
I personally think it's not as important as it is in frontline, because we have not this clear association with the disease course in relapse. When we look on a patient who potentially had 7 or 8 lines and then showing a deletion 17p, I think this is not a true 17p patient who would never make it to 7 or 8 lines. And we are not sure what does that now mean. And we know that myeloma is a clonal, very heterogeneous disease. However, I think that especially with the upcoming potential molecular targeting, especially the probability of giving venetoclax, if not available or clearly shown, then I would always look even in relapse if, for example, a translocation 1114 is there. We know it's stable, you don't have to prove it again, but if it's not proven before, then we should potentially look on that.
Okay, but I understand from your answer that you do not advise routine cytogenetic testing at every relapse or progression, only in special indications.
Absolutely, yes.
Okay, so thank you for that. You already referred to MRD, Minimal Residual Disease. So if we look further than just cytogenetics, would you like to say something about the prognostic value, or high risk or standard risk with respect to the MRD status?
Yeah, I think MRD is an important goal for us, as it is more predictive in regards of outcome than it is with the complete remission or immunofixation negative remission. We have currently 2 major methods measuring MRD. One is the next generation flow, which is very well standardized in the Euroflow consortium, and also next generation sequencing, and which is more used in the US potentially. And although it is not routinely established in clinical routine, I think the data are showing very consistently for both standard and high-risk disease that when achieving MRD negativity, that this is translated into a better progression-free and also overall survival.
Yeah, I think your message is quite clear here. That's, I mean, cytogenetic diagnostics are done at diagnosis. But here we have a new high-risk feature, which is a patient who does not achieve MRD negativity. And this may be, let's say, an important assessment for further treatment decisions. Do you agree with me?
Absolutely. I think it is now for us a great gift, kind of having the possibility to achieve MRD negativity in a substantial proportion of patients with myeloma. And now there is the time to tailor our treatment, to adjust our treatment, to bring those patients not achieving this deep remission into this MRD negative remission if possible.
So we are running a bit out of time, but I would like to briefly ask you what are the new therapies and new antibodies or immune treatments that you foresee are going to have an impact on high-risk myeloma?
I personally think these are the cellular treatments. They're CAR T-cell treatments currently targeting BCMA. I think that no other method showed in very heavily pretreated patients with partially extramedullary disease burden, those remissions which were, to my opinion, absolutely unprecedented. And I personally think that this is one of the most promising strategies we currently have. Secondly, I personally think that the bispecific antibodies will have an impact on treatment, not all myeloma patients, but also especially those you just mentioned not achieving MRD negativity, and might be a very important tool to turn MRD positive patients into an MRD negative remissions. They have a very powerful potential, in my opinion, to do this.
So if we end now with this podcast, what would be your advice, very briefly, very short, to your colleagues how to work with high-risk myeloma patients? What is the most important thing?
Not anymore saying, okay, you have high risk. We do the same as with standard risk patients, but the outcome is poorer. And to look really critical on the individual situation, and then putting everything together to get the patient in a maximum deep remission. And then there is the chance that even a high-risk patient will have a longer remission than we had before we had all these possibilities.
Thank you very much. And I would like to remind the audience that Professor Weisel very nicely explained what is the cytogenetic risk group that can be defined as high-risk myeloma. She also introduced MRD as a new variable that determines high-risk status in the patient. And she discussed new treatments that have an impact on the outcome in high-risk patients, and maybe use more and more to improve the poor outcome of treatment in these patients, and hopefully bring it to the level of standard risk patients in the very near future. I would like to thank Katja Weisel, Professor Weisel, for her time and her expertise that she shared with us. And I would like to remind the listener that this podcast is number 2 in a series of 3, and you can join yourself and your experts for the remaining one that will come very shortly. And this will be a podcast specifically dedicated to multiple myeloma in elderly patients. I thank you all for your attention and have a good day.